Well, I think it's interesting that his troponin is where it is, because that goes along with the CTO and the slow myocyte fibrosis. There is ongoing damage there. He may not have, most of the time, what it appears to occur is that the collateralization is not sufficient to actually preserve that. So I think he had a relatively low ejection fraction to begin with, and then it went lower. And I think that troponin makes sense given what you've told us, just off the top of my head.
Yeah. So the thoughts in my mind, I mean, and again, question marks. Was an underlying myocarditis driving the risk for the cardiac arrest? There was no occlusion. The pulse score itself, even without an increased troponin level, predicts cardiac events within the next 5 years, whether it's a heart attack, sudden cardiac arrest, stroke, or something like that. Mm-hmm. And so did the cardiac arrest bump the pulse score? I mean, can cardiac arrest and CPR bump the pulse score that you know of? I mean, it's an acute.
Yes, it can.
Yeah.
Yeah, no, it can bump the pulse score for sure.
Yeah. So these are some of the things we're dealing with this patient, and it made me think of the other patient I presented a while back. This patient is a little less clear cut because, there's some issues in the timeline, there's some missing data, but clearly it's a question that needs to be raised. And one thing we're starting to do with our patients, and I'd like to get y'all's take on this. Of course, our patients are skewed toward people with cardiac disease. We have some who don't have, severe cardiac disease, but we're actually starting to use the pulse score and ultrasensitive troponin in people pre and post vaccination. When it's time for their booster, we will also look at their pulse score, and we also measure the antibodies. So I've had patients where they say, well, it's time for my booster, and they have an elevated pulse score, and their antibodies are still good. I'll say, well, hold off. Let's do something, get your pulse score down. You still have antibodies. And if you want to get the booster, we probably should wait and see if the antibody titers dictate that. What say my panelists?
I tend to agree because we're concerned about increasing inflammation. So, and so if you tested for antibodies, immune antibodies, and patient has some immunity, and especially when you're concerned about certain conditions worsening, I could, understand your cautiousness with that patient.
Yeah.
I agree. Yeah, I agree with Dr. Atkins too.
Yeah, I think the approach I like to take is a measured approach that's based on an individual patient as opposed to kind of a blanket approach. Thomas is talking about the S1 attaching to the CD147 receptor of parasites instead of the ACE2, causing vessel damage. Doug, you're a biochemist and pathologist here. Any comments on that?
Yeah. Well, I still believe the ACE2 receptor is the culprit. I'll tell you why. You remember SARS-CoV-1? It primarily manifested pulmonary issues, and it didn't really go to the rest of the body because the cofactor it required was only found in pneumocytes. However, okay.
You like that?
I did. When you look at what SARS-CoV-2 does, its cofactor is called furin, and it's found in every cell in the body, which is why that culprit goes everywhere. And the most dense population of ACE2 receptors is in the endothelium. But I can't rule out other binding, but it's been clearly documented that the manifestations are primarily due to that ACE2 receptor and the internalization of the virus into the endothelial cells and other cells, but there's one other thing that it does that's really interesting, and it may be relevant in this patient. The endothelium is responsible for the micro environment of managing thrombosis.
Yep.
And the COVID-2 and the vaccine both interfere with that, although the COVID infection is significantly more intense than the vaccine, but it predisposes to microthrombi, which is what we see clinically In some patients, they're more susceptible to it. So, bottom line is, yeah.
I'm sorry, go ahead.
Dr. Charles. No, I was just going to say that the real trick here is that we know the underlying pathophysiology. We know why it damages these cells, and we know that all the vaccines, doesn't matter which one, mimic it. Although the J&J clearly has had some more issues because it uses a viral vector. So does AstraZeneca, and I think that's significant because they stimulate more interference with that micro clotting management protocol that the endothelial cells have. So, it makes sense. I was going to, if you want, if you give me a minute, I'd show you 2 real COVID patients and what happened to them, because it's significantly more intense than what the vaccine is doing.
Yep,
you want me to share that with you?
And while you're sharing that, I want to invite people to remember that, it's been thought that the coronavirus infection itself is, let me stop sharing. I'm sorry, there you go. You should get it now. Is a vascular disease. And so many people who catch coronavirus get, vascular problems. But any kind of infection, what I want to say, as you're bringing that up, any kind of infection can trigger a cardiovascular event. Yes, the spike protein binds to the ACE2 receptor, but any inflammatory response that triggers either a systemic cytokine storm or local, regional, that can affect blood vessels anywhere, can affect blood vessels everywhere. And so that's why you hear reports about people who get, tooth infections, getting heart attacks and various other things. So you clearly have a situation where, inflammation by itself can increase the risk of cardiac events. Are you finding the share screen button down there? Or?
You know what? It's telling me I have to restart to be able to share. So how about if I just tell you?
Sure.
Okay, I'll read it to you, and you can imagine it. So I have 2 patients that were being followed for elevated pulse scores, and they were getting them, about every 3 to 4 months, and they were running around the 6.5 to 7 range. And the first patient got COVID in November of 2020, and by January of 2020, their pulse score was up 40%.
Wow.
And this is somebody that's become a long hauler, and they've persisted with an elevated pulse test. The next patient was vaccinated. They were followed for the same thing. Their pulse score was a little higher. It was in the 10 to 12 range. In January of 2021, they had COVID, and within 30 days, their pulse score was above 35%. So a fairly dramatic increase. Now, in the interim, the one that went up to 35 has dropped back down to their pre-COVID levels and is doing very well. The other individual is continuing to manifest symptoms, which suggests that, they've got some ongoing inflammation. So
what interventions were taken in these 2 patients, Doug, particularly the one that had the pulse that's gone down? How were they treated for the long COVID?
Yeah, so the one that had the highest rise and that responded most rapidly was treated with vitamin D, glutathione enhancers, zinc, vitamin C, quercetin, and if I'm remembering correctly, a statin.
Okay.
So
Pam, you're smiling.
Pam,
unmute yourself. What do you think about that? Now, the statin decreases inflammation. What do you think about that regimen, Pam? You're on mute. You're on mute. Pam, you're on mute.
I'm sorry.
No problem. So you were smiling. So what do you think about that regimen?
I do like that regimen. I like the anti-inflammatory nature of the quercetin and antiviral properties for zinc and vitamin. And definitely we know vitamin D is a superstar, so I like that. tend not to use statins as much, but that sounds encouraging.
Yeah, that's
Yeah,
interesting,
no,
Doug.
we agree with that. Yeah. I'm
No,
sorry, I was going to say it was one of my colleagues that did the statin thing after all the rest of it. So
okay. No,
not one of my patients.
yeah, that regimen is very close to our regimen for treating COVID itself. I mean, we
Hmm.
load with vitamin D, liposomal C, quercetin, and zinc. If we use a glutathione precursor, whether it's NAC or MSM or something like that. So it's really interesting that if you look at that regimen, it's really the treatment for the overall syndrome. Now, long COVID is really kind of the lingering, inflammatory process, after the infection has come and gone. But really, that's really the bulk of the disease of infection. If you treat a patient, I was managing a patient, well, two patients, but one in particular went in with cardiogenic shock and sepsis. And, I was talking to a colleague, said, well, the bacteremia is gone and sepsis is over. So no, the bacteremia is gone, but sepsis is not over. I mean, you still have these, cytokines and these inflammatory markers, these mediators. And the way we should be treating these mediators is by means of treating with things, as you pointed out, vitamin C, quercetin, zinc. But one thing we do is we use a raw diet. And so these
Yes,
powerful super
really
greens,
good.
they reduce oxidative stress, they reduce cytokines, and it's in our published paper in terms of inflammatory reduction, et cetera. And that's how I've been treating my long COVID patients. So that's interesting. So that's great presentation. I wish you had this.
Well, I wish I could share it, but I don't want to restart. But let me just tell you that I don't use statins. I actually use something called Swish, which is a compound designed to boost your immune system. It's got ALA, it's got nanoparticle glutathione, it's got NAC, it's got cordyceps, it's got L-citrulline, and the way it's designed is you put it in your mouth like a mouthwash, you swish it for about a minute, but then you swallow it, so it gets absorbed through the mouth first, and then it gets processed through the liver, so the NAC, which needs to be deacetylated in order to become active, gets activated, and it's been really good. We've been using that as a prophylactic. And then I'd like to comment on the vitamin D because we had quite a bit of dispute about this. It's clear that this virus, not only does it damage your ability to use vitamin D, but it enhances an enzyme that destroys vitamin D. So it's not surprising that you've got to have more vitamin D for these people, and then it's very helpful. And zinc, absolutely what Dr. Atkins said. The glutathione allows the zinc to get in the cell. The zinc is like the bullet that targets the virus. So that all works. I love it.
Wow, so that was interesting. I didn't know that about the virus attacking your ability to utilize vitamin D and destroying vitamin D. So there was a study, and I need to look this up. You may be aware of this, Dr. Atkins, Dr. Harrington, but someone reported a study where there may have just been one or two hospitals, but they looked at the mortality, the people that had the highest mortality, or of all the people who died, I think no one had a vitamin D level above 30. Are you aware of that? I need to look that up. I remember seeing that.
Yeah, I'm aware of it. I don't remember. Yeah, I think Henry Ford Hospital did some really good studies too. They studied ivermectin and hydroxychloroquine and caught a lot of flack for it, but they also did some vitamin D studies. So,
Ms. Kay wants to know about NAC.
N-acetylcysteine.
Yep.
Go ahead, Dr. Atkins. You're on.
Go ahead. You mentioned it. I'll let you go ahead.
Okay. Well, what I was going to say is it's actually it's a good it's actually the original antidote for Tylenol poisoning, because Tylenol removes glutathione from the liver, and it's the most common cause of liver transplants in kids. But it turns out there are other things that are more powerful. I actually think N-acetylcysteine is good. The only issue with it is it has to be modified by an enzyme in the liver to become active, which is why it works so well in the liver. And I think it's a good compound. There are other ways to boost glutathione. You can use liposomic glutathione. You can give L-citrulline, and ALA, which actually is very similar to GSH or glutathione. And I did remember a study that showed that in people, particularly over the age of 60, that had severe COVID, they had an endogenous deficiency of glutathione. And by enhancing their glutathione, you mitigated a lot of the severity of the symptoms. So I think it's central. And the other thing that glutathione does is we tell people you can't get some of these drugs into cells without glutathione, and it also recycles things like vitamin C. Vitamin C is an antioxidant until it donates an electron, then it becomes a free radical and has to be recycled by glutathione. So, very important.
Yeah,
Excuse me for
that's
babbling on there.
no, that's great. I mean, glutathione is your super antioxidant. Now, you mentioned a liposomal glutathione. I was actually reaching out to our source and see if we have one. Have you used that, or Dr. Atkins, have you used a liposomal glutathione? I mean, we have an IV form that we give in our IV vitamin C.
I haven't, but I'm interested in finding out more. But that's interesting. I haven't used the liposomal.
Well, yeah, let me give a caution about it because I didn't know about this, but I actually prefer. Somebody asked about Swish, and I just want to make it clear here: I don't work for any drug companies. I don't work for any nutraceutical companies, and I've never taken a dime to endorse something. But I can tell you that Swish is simply a mixture of compounds that are known to enhance your immune system, and they use a technology that nano-encapsulates these substances so they're absorbed more easily. And I think that may be safer than liposomal because I just read an article about neurotoxicity from liposomal glutathione. And it's because the brain regulates its glutathione levels very well and you can overwhelm it. So I don't use it personally. I just know that in some cases they have used it for acute treatment. So, okay.
Gotcha.
Just to be clear.
Yeah, we use it limited over. Somebody asked is available over the counter. I haven't seen glutathione, but I'll just see precursors. So, anybody aware of glutathione available over the counter?
It is at GNC, but can I urge a caution on that?
Yes.
Glutathione is a tripeptide, and it gets digested in the stomach, and you're just basically taking a very expensive protein supplement. I strongly recommend you take something other than glutathione in pill form. IV is fine, taking precursors, N-acetylcysteine, blah, blah, blah.
Yeah, we use sulfonomethane also is anti-inflammatory and also predisposed to glutathione. I got that from Dr. Atkinson. They use that. So that's it. Yeah. So again, from the clinical standpoint, we have a situation, and I'm just going to throw up a news report, and I'm doing this because it's related to our situation, because this whole issue of cardiac arrest is one that we should be aware of. Post-vaccine, long COVID, post-COVID infection. I don't know if it's an issue that we need to be concerned with the variants. Here's one with a 17-year-old cardiac arrest after the vaccine. Now, the deal there is simply we see that in young boys that age, but not so much in young girls, and so that's an unusual case. In fact, it's the prevalence of myocarditis in young boys is I don't know 20 times or something like that they found in young girls in the study. So that's an unusual presentation. But I think what I want the audience to take home from this is that COVID infection is not only a respiratory infection but also vascular disease is becoming endemic. I think most of the data we have is on the original variant. the Delta variant, I'm not sure if a lot of these myocarditis cases are related to the Delta or the original, and I don't know if they're differentiated. Omicron's too new to know. So the question in my mind, I'll throw it out to my colleagues here. Do you think the variants may have a similar vascular effect as the original type? You know, they have some variation in the spike protein. Will the spike proteins be enveloped as efficiently? Will it cause as efficient of vascular damage? Or do we have any information related to that?
I'm not sure the information is out yet on that. We're still waiting for more. But I am concerned about post-vaccine. I'm just researching all these reports and studies are coming back on increased inflammation, not just cardiac tissue, neurological tissue, uveitis, eye tissue, autoimmune diseases. You know, there are a lot of studies coming back, usually from different countries. I've seen a study from Israel on autoimmune disease and inflammation increased, either not diagnosed prior, symptoms, and now newly diagnosed post-vaccine, or if there was a diagnosis, worsened. So it's very concerning, and usually at the end they'll say, well, the risk of taking the vaccine outweighs, and risking infection, outweighs the risk. But if it's happening to you or your loved one, it's very real. And so it's a concern, when we have concern, especially if people already have comorbidities and other things going on, and elevated age, being over 65 or older.
Yeah. I think that risk benefit ratio. Yeah. No, go ahead, Doug.
I said that's young, over 65.
Hey, I agree with that. Over 65 is young. I'm nowhere near that, but I'm still young. I'm close enough to where it's young now. So anyway.
I'm sticking with it.
No, the risk benefit ratio issue is one to be really considered, because the original variant clearly was more virulent. Delta, as some question, was less virulent. Omicron is very likely to be less virulent, more contagious, less virulent. And that's typically what we see with viral pathogens and pathogens in general. As they become more endemic, the respiratory viruses, they become less virulent and more contagious. So the risk of dying goes down very significantly. And some people pointed out earlier that the survival rate of the original variant was, over 99%. So when you get down to less virulent variants, we have to start to then recalculate risk-benefit ratio, especially as we learn more data in terms of the potential harm. Because not only is there, you have individuals that had, like this gentleman had a cardiac arrest. We had another lady with heart failure. There's certainly a morbidity component as well as a mortality component. So perhaps we need to, as we go, further into this, the next phase of, COVID and its variants, should we do a formal recalculation of risk-benefit ratio? Should there be another randomized controlled trial looking at the variants if such a thing can be done? Doug, you have a thought on that?
Yeah, I was going to mention, because we were talking about athletes, that we've noticed that the people that are having problems are people that tried to go back to full activity too early. Like we've had a number of young people that had COVID and recovered and felt great. And then they went out and started doing their usual activity and came back in positive and not feeling good at all. So we try and slow people down a little bit. Now, one of my relatives had a number of comorbidities, and we tried to talk him, and he had COVID and he survived COVID, and we tried to talk him out of getting the vaccine. He got the first dose of the vaccine and died within a day or two. And
wow.
And obviously we had comorbidities, but the thing that seems to have been forgotten is we were discussing herd immunity, which was somewhere above 60% back when, where I think we're currently at 80% vaccination, which doesn't take into it, and that's for B cells, doesn't take into account T cells. In Singapore, half the population had T cells that were active against the original COVID virus. So now we've got Omicron. Yeah, and you're absolutely right. It's hard to find anybody that's died from it. It's in 30 states now, and nobody has actually died from it. And what's interesting is, if we're already at herd immunity and we have a less virulent form coming through, and we know that based on the Israeli study of over 600,000 patients, that natural immunity is 13 times better than vaccinated immunity, why are we pushing the vaccine for this new variant when we're probably already there? So
Yeah, I agree.
I'm not. I want to make it clear, I'm not an anti-vaxxer, but I'm like, I'd rather rely on science to guide the approach. So.
I don't like those labels, anti-vax, pro-vax. I'm anti-nonsense. That's what I am. But anyway,
Exactly.
That's a good point you make in terms of our herd immunity, especially looking at infection rate plus vaccination rate, and pushing the vaccine. One thing we don't know is that, and this guy Gert Vanderbush, he raised, and he's a very prominent vaccine expert. Very early on, he raised the concern of the vaccine's effect on someone's natural immunity. So you mentioned, the friend who died after the vaccine. Now, granted, who knows what the mechanism was? There are reports that people who get the vaccine after getting COVID are more likely to be symptomatic. But the other question that's been raised, at least by Gert Vandenbush, is that can you create, especially with boosters, a situation where you're forcing the body to make a very specialized antibody that's competing with your natural immune system, who's making antibodies that have a more global view of the virus. I mean, when you have the viral infection, you're not only looking at one part of the spike protein, but you're looking at other parts of the virus, the nuclear capsid and other parts of spike protein and the like. And so mutations are less likely to evade the natural immune system, because it's like when an intruder walks in, the vaccine just looks at the nose, but then the natural immunity looks at the nose, the left ear, the right ear, the chin, etc. So if the virus gets the nose job, the vaccine-induced antibody may not recognize it, whereas the natural antibodies will, because it's looking at more than just the nose. So, so that's the other issue that we're looking at. And I think, to your point, Doug, we may be at a point where, hey, wait a minute, we're probably at an end point, and we know what treatments can work against the virus. And some of the things that was mentioned with the long COVID syndrome, immune boosting agents, anti-inflammatory agents, which I think are very, very important.
Yeah, if I could just make a quick comment. I was vaccinated, and I didn't have any symptoms, but my wife started not feeling good, and she couldn't get vaccinated because she was being treated with chemotherapy for a reason. And I said, I'm going to test you, and she didn't want to be tested, so I tested myself just as a joke, and I was positive, and I obviously gave it to her because she tested positive then. And, she wasn't doing too well for a day or two. And because of her condition, I took her in and I insisted that they give her the Regeneron artificial antibody treatment. And they didn't want to, because they have this 15-point questionnaire you have to fill out. And she only qualified for 3. And I said, well, you know what? She qualifies for a 4th, which is she's under active chemotherapy. So give it to her. And they did. And the turnabout, within 24 hours, she was remarkably well, and she did very well post that. And the oncologists were all shocked. They couldn't believe it. They were going, I don't believe this. So, that's a poly-specific cocktail, so it's got, I think, 2 components that attack different things. And So and then the reason I made this point is because we have learned more about it. Fluvoxamine, which is a psychiatric drug, it's a psychoactive drug, which is used for other things, actually reduced hospitalizations by 50 to 80%. And we've learned a lot. So I don't think there's a reason to be afraid now. I think we need to just be cognizant of what the tools are that we have that actually work,
And not to mention the eye drug, which has been used very successfully in many states in India, as well as other parts of the world. Which is anti-inflammatory.
And it actually facilitates getting zinc into cells as well. I looked at that one province in India where they had a 90% hospitalization rate, and the place was out of control. They put together a kit, which included all the vitamins that Dr. Atkins talked about, plus the eye compound, and they had a 90% drop in the rate of infections, transmissions, hospitalizations across the board. It was amazing. So.
And they had the same thing in many states in Peru. They had Mexico's as using that compound, as well as other natural agents. And are you familiar with the Flccc protocol, Doug?
I might be, but run it by me.
Well, Dr.
You said
Pierre
those letters
Corey,
too fast for me.
I'm sorry. Yeah, Dr. Pierre Corey is probably one of the more prominent speakers. And I'm blanking on the lead guy of the group, but there's a group of intensivists, pulmonary care, critical care doctors who have this a protocol and it's based on all the science. And they started with hydroxychloroquine, the eye drug. They use intravenous vitamin C, thiamine. They actually, I think, use a statin. They use anticoagulants. Dr. Merrick, thank you, TP. Dr. Merrick is also Dr. Pierre Corey and Dr. Merrick. And Dr. Merrick is kind of the more senior guy in the group. And again, they put together this protocol, FLCCC. They've done some amazing work in bringing out the evidence. And I actually started adopting their protocol early on. They use quercetin, zinc, fluoxetine. So they're very advanced in terms of using that. So Dr. Joe Verone here in Houston, he runs a hospital. I think he has probably the best survival rate of very sick COVID patients worldwide. He's certainly his rates is far better than the average, not international average. But he's using this protocol, and he's part of that FLCCC group. So I invite people to look up FLCCC. It's FL, all caps, FLCCC. I'll put that in the chat if you want to Google flccc.com or org, I think, which one or the other. But they have an excellent protocol, and they show a lot of the data supporting the use of their protocol. So it's really scientifically based and not just conjecture. And so, have you looked at any studies about the breakthrough cases here in the States, Doug or Dr. Atkins?
I looked at one out of Israel that was done very well. It was one of the ones I referred to earlier. What they did is in February of 2021, they took, there were 676,000 patients in the study, but it was about half and half. Half the people had a natural infection and the other half got a vaccine. And they looked at the breakthrough, or whatever you want to call it, infection rate. It was like extremely small, 0.25 or something. And when they looked at the likelihood of that occurring, it was 13 times more likely to occur in vaccinated people than in people with natural immunity. And a lot of the people that did break through had comorbidities. They weren't totally healthy people. So, I haven't seen really good studies in the US yet that are quite that big and well done, but the Israeli one was really well controlled. And
and we actually we did a show on that. We reviewed that on the show, and there was a 27 times benefit over symptomatic COVID. I think the 13-fold just kind of all positive tests. When you looked at symptomatic COVID,
Right.
I think it was like a 27-fold benefit, natural immunity versus vaccine immunity in that study. And there was also a study that just looked at natural immunity, I think in Great Britain. I think there were about, I don't know, a number of hospitals. It was a multi-center study looking at healthcare providers. And they looked at the reinfection rate of healthcare providers with infection versus no infection. Now, they started before there was a vaccine. And again, to your point earlier, a very low reinfection rate, compared to those without the infection. And so these were healthcare workers. So these are people who were highly exposed. So there was a cohort group of people that were highly exposed, which I think is an important thing to point out, because if you look at all comers, people that are hiding under the bed 24/7 are different than people who are out there treating COVID patients every day. And so the natural immunity is robust even in the setting of high exposure. So great.
So here's a little story. Our team, we have a not-for-profit foundation called the Garda Heart Foundation, and we go out and do events. And what we did is we were invited by like South Central LA, Crenshaw, Baldwin Hills to go in there because nobody would go in there. And we brought a team of people. We had 10 tents, and we did like 1,000 people a day. We tested them both for antibodies and if we needed to, we did swabs. And what was interesting is the majority of the people that we tested who had positive antibodies didn't have symptoms, or they thought they just had a cold. Okay, which is kind of fascinating to me. And we also found that, like for instance, in Crenshaw, Baldwin Hills, they had an active community program where they gave free hand sanitizers and masks and talked to people about how to prevent infection. And most importantly, what they did is we had worked with them ahead of time. We had a lot of families there that had multi-generational families in the same dwelling, and we only had one bathroom. And if you don't know it, a toilet can fling droplets up to 20 feet away. And COVID is very much present in the poop and pee of people. And so what happens is it was spreading through families through the bathrooms. So we got that done, and they dropped their infection rate really low by that community program. It was really, really well done, so.
What did they do?
What they did is
I'm sorry.
They taught them to close the toilet lid before flushing, to step to the side, keep their mask on, and wash hands heavily afterwards. But my point on telling you that was, we did probably 10,000 patients, and I was there the whole time. And there were a lot of sick people that came through the thing. I didn't get COVID there. I got vaccinated after all of this because, I haven't been able to get vaccines in the past because I'm allergic to eggs. And I was driving up here to Montana, and I stopped in Vegas to spend the night so that we could get all the way there. It was on a weekend. And I don't gamble. I didn't do anything else there. But I ended up getting COVID in Vegas, of all places.
Wow.
That was
stopped to use the bathroom there or something, or what?
No, I stopped and stayed in a hotel overnight because we were tired and driving.
Gotcha.
And we ate dinner at one of the restaurants there, probably picked it up there. I just, that was the only exposure I had that was outside the norm. So anyway.
It's one of those things.
Story.
Yeah.
My wife now calls me a super spreader because I had no symptoms, and she got it from me. So I'm in trouble.
Yeah, I haven't. I did the T-detect. I haven't been vaccinated or anything, but I did the T-detect test, and I haven't. That was maybe a couple of months ago. I haven't caught it as of then, so maybe later I may get some. But I had relatives who had COVID who came here to my house, and they wanted to get supplements and things, and I was around them without a mask and all that stuff, and so I still didn't catch it. So I don't know. I thought I had caught it before, and I didn't catch it. So maybe I'm just too ugly for COVID or something. I'm not sure. So either way,
but
Any final comments for our audience as we wrap up here, Dr. Atkins? You go first, and then Dr. Harrington, and then I'll close us out.
Well, I just think it's powerful information from these studies that we have, or cases that we have about the acute inflammatory changes that we see, and so we need to be mindful about that as doctors, physicians, or patients, to think about it when we have some type of condition to start with, or a combination of conditions, to think about if we increase the inflammation in our body, the risk of it. So I think we should have these discussions with our doctor about the risk benefit. Even if the doctor doesn't bring it up, the patient should.
Excellent point.
Right.
Before I get your comment, Doug, what's your link? How can people contact you?
I hide in Montana. I don't know. No. So the best way to reach me is to go through www.pulsetest, that's PULSTEST.com, and leave a message, and we'll revert back to you. Okay.
Wonderful. Okay, I'll save that in as a banner.
I have one more thing to say real quick.
Yes, please.
I think the pulse test, I just wanted to tell the audience I was impressed with it, and also how it tells your physiological cardiac age. You have your age, and you have the age, physiological age of your heart. So I thought that was very interesting, and when, that gets your attention when you find your heart, for those that the heart is much older than your actual age. I had one patient that her age was 62 and her heart age was 69. So that got her attention.
Yeah, that's a good point, because people pay attention to that more than anything.
Yeah.
But
we
I will
catch
say
a lot of flack.
Well,
Sorry,
I
go
will
ahead,
say
Max.
one of our patients he's I think 94, 95, and he's doing very well on our plant-based diet. He eats mostly raw. He's pretty active with having him do some squats and exercise and things. And so his age, and it says greater than 80, and it said, well, it doesn't quantify greater than 80. He says, well, that's not right. There are a lot of people who are older than 80.
Tell him
so
his heart age is
So,
70.
Yeah, his heart age may be 70, but anyway, it just gave him greater than 80. But he may be much better off. Any final words?
We should extend the range so we can,
Exactly.
Yeah.
Exactly.
Yeah. And they want me to go below if you're lower than your heart age. We have a lot of people that come in lower than they're expected, which is interesting. So, sorry,
that's true.
I cut you off.
No, that's true. No, increase in range, I think, is key. But your final comments, Doug. What thoughts you have regarding the pulse test and et cetera?
Yeah. Well, look, the pulse test is just an additional tool for doctors. It's not meant to replace anything your doctors do, and I want to stress it doesn't substitute for common sense. So you want your doctors to work with you as a patient. And I find that most of the time patients tell you what's wrong with them if you listen to them. But the pulse test is valuable for identifying vascular inflammation. And then we use that same information to calculate a risk of having an acute coronary syndrome, which is a heart attack or a stroke or unstable angina in the next 5 years. But it's not a death sentence, it's a check engine light. And that's what people need to remember. Even if you're in the red zone, you've got plenty of time to do something about it. And I can't tell you how much Baxter has impressed me with what his patients do. And I know Dr. Atkins is down the same pathway. Let's treat the patient and not give them a pill and say you're see me in a year. But I think as it relates to COVID, I would just like to say that I don't think we need to be afraid. And I think if you don't believe everything you read on the internet and you try and get good sources of information, and it's basically there's so much garbage out there right now. I can find 20 tests that say 20 papers that say ivermectin is crap and 20 that say it's great. And how do you as a layperson understand what the truth is? Well, it's hard enough for doctors. So if you just keep a healthy skepticism and realize that I think we're at herd immunity, and these people that are afraid of unvaccinated people that are vaccinated, they don't really have anything to fear from unvaccinated people if they truly believe in the vaccine. It's the people that are unvaccinated that should be afraid. So there's a lot of garbage out there. So I think there's hope, and there's lots of things going on that are so good, and we don't have to worry about death. And so there you go. Okay.
Last quick
I
question.
see a
Tom wants to
question.
know, yeah. Is the pulse available in Europe
Tom.
and Germany?
Yeah. We have a distributor in Canada and in Asia, and we have one in Germany, but they're not active yet. They're working towards it with a lab called SynLab. So we'll keep you posted. Okay.
Wonderful, wonderful. Well, as always, guys, I learned a lot. Thank you very much, Dr. Atkins, Dr. Harrington. I appreciate everything you've done. Our audience, give our guests a digital round of applause. Those of you in the chat, please give them a digital round of applause. Thank you very much. I'll see you two behind stage, and I'll close out. Thank you very much. Great discussion. Well, as usual, we had a great discussion, and as usual, I learned a lot, and hopefully you've learned a lot. And of course, I want to remind you to hit the like button so this video will get more views, and also subscribe if you hadn't had a chance to do so. And of course, if you think you have a loved one, friend, colleague, or anyone you think may benefit from this information, please share it, especially someone who has cardiac disease or may be at risk for cardiac disease. I think a lot of valuable information has come out of this, and I think this is something that you or your loved ones can benefit from. So again, I like what Dr. Harrington has said, and also Dr. Atkins has said. We have to listen to our patients. We have to treat the whole patient, and we have to treat the patient's whole body. We have to treat you naturally, get your immune system healthy and enhanced. That's going to be your best defense and your best treatment for any condition, let alone coronavirus or long COVID disease, or even toxicity from a vaccine. Again, the treatment is all the same. You want to enhance your body's immune system, enhance your body's ability to heal itself and reduce inflammation and the like. So again, as always, thank you for listening. Please like, subscribe, and share. And by all means, share with loved ones. Until next time, keep it fresh, natural, and live.